The Pender Health Promotion Model was created in 1982 by Dr. Nola J. Pender after doing a research study that examined health promotion, health, and well-being. She realized that healthcare professionals only intervened after patients develop acute or chronic health problems. The Pender Health Promotion Model focuses on helping individuals prevent illness through their beliefs and attitudes, but also allows them to pursue a higher level of well-being. This health model understands that an individual's characteristics and life experiences have a direct impact on their actions and decisions regarding their life. To be executed successfully, this health model understands that individuals must work alongside their healthcare professionals, such as nurses, to create and follow healthy lifestyle behaviors. The Pender Health Promotion Model states that each person has unique personal characteristics and experiences that affect subsequent actions. It is broken down into 3 areas: individual characteristics and experiences, which include prior related behaviors, and personal factors such as biological, psychological, and sociocultural. The next area would be behavior-specific cognitions and affect, which include perceived benefits of action, perceived barriers to action, activity-related affect, perceived self-efficacy, and situational influences, such as options, demand characteristics, and aesthetics. And the last key area would be behavioral outcomes, which is immediate competing demands, low and high, commitment to a plan of action, and health-promoting behavior. The interventions for this research study were the focus groups, training courses, demonstrations on small rough models, brochures, and telephoned monthly reminders from nurses about early diagnostic behaviors. These were the tools to help the women of this study create healthier lifestyle choices when it came to early diagnosis of breast and cervical cancer. Although what separated the experimental group from the control were the differences in how many preventative interventions were given. The experimental group received the training courses, focus groups, extra demonstrations on the models, brochures, and monthly telephone reminders from nurses, while the control group only received the focus groups, training courses, and the brochures. As stated before, the purpose of this health model was to stimulate a behavioral change that resulted in positive health outcomes. And to do that, the Pender Health Promotion Model not only needed there to be a strong commitment from the individual, but also have nursing interventions that could be tailored to those variables to assist in forming positive change. A nurse must create a plan that tailors to the individual's self-worth, benefit for change, environmental control, and any potential barriers to change. This concept was used in the article by giving the subjects of the study many learning techniques and extra reinforcement to have more preventative health behaviors. An example of this was having the focus groups and training for both groups of the study, but only monthly phone calls for the experimental group, which resulted in better lifestyle changes.
The purpose of the study is to promote breast cancer and cervical cancer early diagnosis behaviors, which include self-breast examinations, clinical breast examinations, mammograms, and pap smear tests. The study is to see if nursing interventions such as trainings, demonstrations on how to properly perform a self-breast examination, receiving learning vouchers about cervical and breast cancer, receiving monthly reminders from nurses about early diagnosis behaviors, and receiving reminder cards can increase positive health outcomes in women. The nursing interventions have been based off of the health belief model and the health promotion model. This is a quasi-experimental study. To collect the information needed for the study, researchers used a sample of 100 women who accepted to participate in the study. They split the women into a control group and an experimental group, 50 in the experimental group and 50 in the controlled group. This sample did not include women under the age of 40 who have previously found a lump in their breast, who have been diagnosed with cervical cancer or breast cancer, who have regular self-breast examinations, or who have had a pap smear, a mammogram, and a clinical breast exam within the previous year. Also, women who have had a hysterectomy have been excluded from this study. The instruments used to collect data in this study were the socio-demographic characteristics information scale, the adapted versions of health belief model scale, attitude scale regarding the early diagnosis of cervical cancer, self-efficacy scale, healthy lifestyle behaviors scale, health responsibility subscale, and information form related to previous behaviors consisting of 4 questions which have been prepared by the researchers by consulting Pender have been used to collect the data. The data has been collected by the face-to-face interview method, and all the data collection instruments have been completed by the women in both the pretest and the post-test. The data has been evaluated by the SPSS 15 computer program.
In this study, there was a meaningful difference in the score averages of the women in the experimental group when compared to the women in the control group in terms of post-nursing interventions regarding breast and cervical cancer early detection behaviors. Rates were significantly higher in the experimental group compared to the control group post-interventions concerning women's perceptions, women's behaviors, and women's health responsibility for the effects of breast and cervical cancer early detection diagnosis of the woman. As far as women's perceptions, such as breast cancer sensitivity perceptions, seriousness perceptions, health motivation perceptions, self-breast examination barrier and benefit perceptions, self-breast examination self-efficacy perceptions, and mammography and pap smear barrier and benefit perceptions, score averages in the experimental group have been found out to be higher in post-nursing interventions than pre-nursing interventions. For women's behaviors, 84% of the women in the experimental group have regular self-breast examinations, 22% of them have clinical breast examinations, 34% of them have mammography, and 38% of them have pap smear tests. Only 12% of the women in the control group have regular self-breast examinations, 4% of them have clinical breast examinations, and 6% of them have mammographies. For women's health responsibility perceptions, when the experimental group is compared to the control group, there has been an increase in healthy lifestyle behaviors, scale health responsibility subdimension score average in only the experimental group with regards to post-nursing interventions. It was previously stated that the participants in the experimental group received training and were asked to show what they learned on small, rough models and got handed out brochures. They were also telephoned monthly and reminded of early diagnosing behaviors and have been made to use reminder cards prepared together, while the control group did not apply any training or receive reminders. It is evident that the nursing interventions increased awareness and affected perceptions positively. These findings shed light on breast and cervical cancer early detection behaviors in women. Women that did not receive the nursing interventions had no meaningful, significant change in their score averages during their pre- and post-interventions. In fact, some of their score averages even decreased. This study shows that it would be beneficial to implement in nursing care nationally and regionally by not only helping ensure that health promotion is being given, but by showing women how to self-breast exam and why these early detections are important. The more education and intervention, such as phone calls, reminder cards, and trainings the patients receive, the more their perception regarding the early diagnosis of breast cancer and cervical cancer are optimistic.